Thanks so much for the introduction. When I sent over one of my bios, I couldn't say at the time that I took a position very recently. I start literally on Monday as the vice president of audiology and innovation for Amplifone, which is they don't sell a hearing aid. They're industry in the sense that they are a network of 18,000 clinics around the world. Um, so it's a little bit different. It's not necessarily doing like market research on that side, but it's leading like the care of the largest hearing care network, which I'm very excited to do as my next endeavor. I think most of my grants now are winding down. I still have a consulting role on I think five different RL1s that will remain, but I'm no longer the MPI of any. And the only other thing to disclose is I was on the scientific advisory board of Neosensory um, within the past 3 years, but they make a haptic device for it was originally for tinnitus. When they started doing it for hearing care, though, it sort of conflicted with my research, and I decided I had to step down. So, just disclosing over the past 3 years. Um, Broadly in this space, I am a clinician, as Holly mentioned. I am an audiologist. I still see patients, but believe it or not, all my research is on older adults. I see pediatrics. I only do kids, and this says a lot about our field, but and it's going to be kind of relevant to how I open up. I literally, when I was at Georgetown University Hospital, full-time clinician at the time, seeing only pediatrics, I was asked if I could start taking on older adult cases because the hospital got a contract to run hearing care at a nursing facility. And it was a lot of dementia cases. And basically, they looked at the dementia cases and said, well, we have this thing to honor the contract. We might as well have our pediatrics person do it. And that says a lot about where our field was. And that was about 15 years ago when I was first starting out. That's sort of our place. Since then, I've done a lot on policy. I'm not going to talk much about policy today, but if anybody wants to know what it's like to work in Bernie Sanders' office for 3 months on the Build Back Better care for Medicare expansion, happy to talk about that. If anybody wants to know what it's like to have Elizabeth Warren and Chuck Grassley scream at each other over over-the-counter hearing care, I'm happy to talk about that, or writing a testimony for Congress and what that's like as a public health person. And it's a doozy itself. But today I want to focus a little bit in on hearing loss among older adults, how it's related to sort of broader health outcomes and results from a recent trial. And I'm going to weave in something I've done in my career is specialize as the leader of an audiology core that adds measures to epidemiologies. And over the past, I think, 6 years since I started that, we've now surpassed, I think, 100,000 people within epidemiologic studies where we've added a hearing test to them using best practice principles. And I will say that if anybody's interested in that kind of data, it really is something that is almost untapped. But now a lot of these data sets are public. We have 4 rounds on the National Health Aging Trends study that I sit on the steering committee. I would encourage anyone to use that. I'm always happy if you want to send an email to quickly connect you to the right spots, if any of this tickles anyone's fancy. So when I think about hearing loss, I sort of use, this screen. Sorry, I'm trying to get something off my screen from the PowerPoint. There we go. Uh, Most people, when they think of hearing loss, they think of understanding some speech. But it's a little bit more simplistic than that. Hearing is really the act of peripheral encoding, right? If you have a word in the environment around you, like Sunday, the ear only functions to encode that sound and then sends it to the brain, right, for actual processing and decoding. And when you're processing speech, now you're starting to get into more of a cognitive process in general at that point. You're adding language to it, you're adding meaning to it. Uh, but if you have a distorted signal coming in, let's say you do have some hearing loss, and you get something like, let's say, unday instead of Sunday because you're missing some high frequency sounds, it becomes sort of an effortful listening part where your brain is now working in overdrive to kind of make sense of sound, right? I actually think of it like listening on a bad radio signal. Hearing loss is not a volume issue, it is very much a clarity issue. And if you're listening on a bad radio signal or maybe more realistic to more modern times is a bad cell phone signal, and you're having an intense conversation. I think all of us can relate to the concept that it becomes effortful, right? You are tired because you are listening to something where you're constantly filling in the blanks, and that is closer to what hearing loss might be like in the real world. I think most of us know there's a lot of hearing loss out there, but I don't think most of us realize just how prevalent it is. This is using 2020 census estimates and using nationally representative data from the United States. And once we get over, these are just done in decade bins. 1 in 4 adults have hearing loss between 60 and 69. But if you want to map it backwards a little bit, once we get over the age of 60, half of all adults in the United States have hearing loss. Once we get over the age of 70, 2/3 of all adults. More recent data that we published in JAMA Open, we actually got our first look at adults over 80 and what that looks like. And the truth is, once we hit 85, basically all of us will have hearing loss. But what's really unique too that's happening at 85 is we're moving into a plurality of the hearing loss being moderate or severe. Before that, it's very mild, right? You know, if you took the 40 million Americans who have hearing loss, 35 million, 36 million of them will be mild. But moderate is where hearing aids are really needed. You cannot get by very well without hearing care, without some form of hearing care or some more significant intervention once you hit that moderate loss. Whereas mild loss, you know, in some situations, you know, if there's no background noise, if there's good lighting, you know, or just if you're, you know, you're doing well cognitively, you can overcome conversation a little bit and you can usually fill in the blanks a little bit easier. Um, at the same time, hearing aid use is low, very low. If you use industry numbers from manufacturers, you get around 30% of Americans with hearing loss own hearing aids. But if you use nationally representative data like the NHANES study from the CDC or NHATS that I've used, you get closer to around 20% of adults with hearing loss use hearing aids. And the key difference is the manufacturer data is based off of purchasing, whereas this data is based off of self-report. Do you own and use them? And there's a pretty big gap between the number of older adults, especially who have bought hearing aids and are not using them. And so it does speak to a bigger issue than just, you know, buying hearing aids. It's not all access and affordability. There's also something about the care models that are not supporting people long enough. And this, to me, is also an equity issue. This is data that I published a few years ago, actually, in JAMA Internal Medicine. And it's under review. I was hoping I would be able to share it today, but I want to hold it. We have an update on this, but starting looking at data from 2011 to 2018, we were looking at the uptake of hearing aids by adults 70 years and older in a nationally representative survey, and we see an increase of 23.3% overall, which sounds wonderful, right? You know, caution, when you start with low absolute numbers and you throw percents on it, you know the percents look bigger than might be reality. But, you know, we are looking at like something like 600,000 or 700,000 older adults over this period adopting hearing care, additional adults, which is a good thing. But the numbers, when we look closer, white males see a 28.7 increase, black females see only a 5.8 increase. And when we looked even deeper, it really is driven by a federal poverty level. Older adults living below federal poverty level, adjusted for wealth and age, saw a 13% decrease in hearing aid ownership in this period. Whereas living at 200% or above, we didn't even go to 400, but 200% or above, we saw a 30% increase. This is really disturbing for someone like me who thinks a lot about policy, because what's happening between 2011 and 2018, we have the largest Medicaid expansion in this nation's history under the ACA. And we went from 10 to 29 states covering hearing care. So quite literally, the group that should benefit from the largest expansion in hearing care coverage in our country's history actually saw a decrease in ownership, which again speaks to there's broader problems here. And we're not going to solve all the problems today or any point in the near future. But I think the crux of some of the issue is this when it comes to older adults. If we had this hearing loss, this is just a mild hearing loss. The yellow region is normal, quote unquote normal, and we had a 12-year-old, we would know what to do. We would immediately say this person needs hearing aids. Here's the course of action, and we know what happens if we don't get hearing aids. We've done a lot of research in audiology from the 60s and 70s showing that if this hearing loss were to go unaided, John Smith's, educational delays would be X number of years, right? Language delays would be X number of years, right? Potential life course, issues could be socioeconomic. Some may even be mental health. We've studied a lot of that on the pediatric and adolescent side. But if John Smith is 72 years old, we basically have no answer. And we sort of just shrug our shoulders and say, well, I guess you could get hearing aids. And we have almost no coverage in this paradigm because we haven't answered these questions. So for John Smith, who's 12, we have mandated coverage. We know what to do. Most insurances cover it. John Smith, who's 72, we don't really know what the consequences of age-related hearing loss are. We don't know the impact of treating it, and we don't know how to effectively address it in the community still. We've pretty much ignored a lot of these basic principles. And so our work approaching it from this more macro perspective that hearing care, sensory in general, is how your brain interacts with the world and then relates to healthy aging outcomes like social interaction, like cognition, like physical activity, is sort of the basis for us pushing on where hearing loss fits into healthy aging. And I'll focus a lot for cognitive vitality and avoiding dementia. Uh, in this area of literature, we've seen an explosion over the past since 2011. So over a little over a 10-year period, we saw a 340% increase on papers of age-related hearing loss and cognition in PubMed. And that's just PubMed index papers. So it has been an exploding area. And it really doesn't just start recently, even though that seems like the case. Way back in 1989, we have a paper in JAMA showing that older adults with dementia, this is a simple case control study, very, very low level of evidence in some sense, but and only done really once with no follow-up. They just showed that older adults with dementia were more likely to have hearing loss. Then in 2011, we start to revisit this, and Frank Lin, my longtime mentor at Johns Hopkins University, he publishes a piece on hearing loss and incident dementia, and a few papers on hearing loss and cognitive decline, including this one. This paper is done with the Health ABC study. For those of you who know, Health ABC is a study that was originally, I think, 3,000 older adults in Pittsburgh and Memphis over 70 years of age. Some are still being followed in ancillaries, but it's pretty rare at this point. The study is aging. At this stage, there were 2,000 older adults followed for a 6-year period at minimum, who had completed the 3MS, a sort of mini mental status exam, abbreviated, and then the digit symbol substitution test. When we look at the 3MS, which is a cognitive test that uses oral input to ask questions, meaning you have to have some audibility to complete the test, we're looking at normal hearing and the dark circles, hearing loss in the open circles, and the slope of their decline of cognition test over time. We see that those with hearing loss had a 41% faster rate of cognitive decline in the 3MS. The digit symbol substitution test, we see a similar pattern. The digit symbol substitution test is a test where you're decoding information. So you're presented a code, right? And then you are assigning numbers to it, right? You're sort of moving it as fast as you can. So it's a different form of cognition. It also is a test, though, where there's no auditory input necessary to complete the task. We can give the tasks in written instructions, and we can make sure the participant understands ahead of time. That's not possible with the 3MS. And what we actually see is a 32% faster rate of cognitive decline among adults with hearing loss versus no hearing loss. And I actually highlight this as an early study in the space and an important study because it actually gets at one of the big, I think, criticisms of this area of literature, which is, well, if someone can't hear, then they can't do cognitive testing. And that's not really true. There are plenty of cognitive tests that we can do without auditory input. We can make sure the person understands via multiple verbal domains. hearing loss and incident dementia, the other paper that came out at this time, this is from the Baltimore Longitudinal Study of Aging. It is 639 adults followed for at least 10 years. The standard Kaplan-Meier up in the corner, no one has dementia. And then by hearing loss category, we're looking at incident dementia among these adults. Those with mild loss, 1.8, 1.9 hazard ratio. Mild loss, 3 times hazard ratio, and then severe loss, almost 5 times. I put a big asterisk, though, myself on the moderate and the severe loss categories here, just because I do say take a look at the confidence intervals. They are really wide. And when we've done follow-up studies with Jennifer Deal, a very close colleague of mine, we actually see, again, revisiting the Health ABC study, older adults 70 years and older, followed for 9 years in this study or in this analytic sample, we see that mild loss was actually not associated with any difference in hazard incident dementia, and moderate and severe and greater, like moderate or greater loss. So we're coding it here as moderate severe, was associated with a 1.5 times hazard ratio of incident dementia. And I think that this study, while the other one gets a lot of press because the numbers are big, right? You're hearing 5 times the risk of dementia with severe hearing loss. This study is probably closer to the norm. In that Health ABC study, one of the issues was you're also looking at some of the healthiest of healthy, and like we only have a very small number of adults with those more moderate, more severe hearing loss, right? Even the mild loss is relatively rare within the study. For anyone who knows anything about BLSA, it is a study that was essentially recruiting very healthy older adults. Had they really thought about hearing loss when they started the study, they probably would have excluded adults with hearing loss. So you're looking at kind of a different sample versus something like this, which is just a general population of 2 areas. So then we see our explosion of literature, an explosion in these systematic reviews on hearing loss and cognitive decline, hearing loss and dementia, doing meta-analyses, systematic reviews on hearing loss and cognition, hearing loss, physical activity. And then the big one that comes out is the Lancet Commission, the first report in 2020, where they did a meta-analysis and we see about a 60% increased dementia risk associated with hearing loss. Then they come out with this population attributable risk fraction, where they're taking a look at, and if we were in the room together, I would ask for someone to explain this. My favorite thing about this slide is I've probably presented it now 50 or 60 times at least. And every time I've asked someone to explain it, the only room where I've ever been in where someone jumped up was a room full of surgeons. And very confidently, 2 surgeons explained it and completely biffed it. This is definitely, I actually think, more advanced epi to think about attributable risk fraction modeling. What they're saying with this is after doing these massive meta-analyses of potential causes of dementia, you have 60% of the risk is unknown. We're looking at genetic, right? We're thinking about Alzheimer's disease at that point, right? And then 40% potentially modifiable across the course of your life. And then they bin them out into the different risk factors. And the way to interpret that 8% for hearing loss is if you eliminated all hearing loss in the world, you would eliminate 8% of dementia. So I actually think it's important that we really start to think about what does that mean on a more macro scale? What does that mean for population health? And remember, hearing loss is incredibly common. So that means if you're wiping out all hearing loss, you are taking away hearing loss from all these older adults, the population attributable risk fraction is spread across many people. So at the individual level, I actually think that it's safe to say hearing loss probably is not the number one reason you're going to or not going to get dementia. But at the population level phenomenon, yes, we do see an association. It's important for public health planning. It's important for policy planning. But telling one individual that, hey, avoid hearing loss or get hearing aids and prevent dementia is probably not the one thing that's going to do it or not. But that's true of many public health things, right? It's a difference between individual and population level interpretation of our data, which I think anyone in your biostats and epi department could say that is something we miss all the time. The way people interpret risk, right? They interpret it for their own individual level, even though what we mean is the higher risk is at the population. But it does also mean that if you compare hearing loss to some of these other areas, right? Smoking is a lot less prevalent than hearing loss. Traumatic brain injury is a lot less prevalent than hearing loss. And that means that at the individual level, risk is probably stronger for those ones because there's a lot less people to spread across, right, the exposure. So it's important that we don't say that hearing loss is the largest modifiable risk factor, right? It's important that we interpret it the way it's meant to be interpreted, which hearing loss is very common and it is a risk factor. And it is so common that it ends up eating up a large chunk of dementia compared to some other things. But there are other things that are a lot less common that at the individual level are probably stronger. So how do we get from all of this observational work, right? How do we get from hearing loss to cognitive decline? And the truth is we don't know, but there are some pathways that we think it might be linked. Cognitive load, this is very similar to what we talked about in the beginning. If you're listening on a bad cell phone signal all the time, right? You will have this issue where your brain is working in overdrive. You're going to recruit another area of the brain to make sense of sound. We actually see this in fMRI, where we see that adults with hearing loss have compensatory language-driven activity in prefrontal cortical areas. But this will come at the expense of something like working memory, because unlike the phrase you only use 10% of your brain, not true. You use 100% of your brain. It's working all the time. If it's working in overdrive, that extra energy comes at the expense of something else. We also have evidence for direct effects on the brain. Auditory signals actually go the entirety pathway of your auditory brainstem, and then they're interaxial. They go to the different sides of the brain. They cross the hippocampal region. They very much obviously are involved with the temporal lobe region where we do most of our processing for auditory signals, and then they hit the prefrontal and frontal cortex. So they are very much something that's stimulating a lot of different areas. We see not just atrophy in the temporal lobe, but we also see overall lower gray matter volume, lower white matter volume. We see recruitment of executive networks outside the primary auditory cortex in adults with hearing loss. We also see different changes in white matter hyperintensities, which is a very recent paper our team put out in JAMA Neurology. And so we believe that even aside from just the auditory pathway stimulation, there are other areas of the brain that are receiving less stimulation when you have poorer auditory signals. And then the last one, I think, is probably the nearest and dearest to most clinicians' hearts, is we've seen social isolation linked to hearing loss over and over again. And then we've seen work from people like John Cacioppo, who passed away way too early, but had brilliant work showing that social isolation, regardless of physical activity, regardless of perceived loneliness, older adults who are socially isolated had biologic objective changes to their body, increased inflammation, changes in upregulation of pro-inflammatory cytokines. No matter how much we want to think about maybe, I'm sure all of us have dreams every now and then of being like, oh, I just want to get away from it all. I want to go live in a cabin. I don't want to see anybody. Humans are social creatures, and you may not necessarily feel lonely being alone, but isolation does have an effect on us, regardless of physical. This is just work from John Cacioppo's team based off that as summaries. Just looking at how social isolation is related to health behavior pathways, our psychologic pathways, our physiologic pathways. It is a huge impact. And there's actually there's an AARP report that's not that old that was featured in the 2023 Surgeon General report on social isolation in the United States that suggests that if you consider social isolation its impact on dementia, social isolation may actually account for more Medicare spending than any other condition. There are also non-causal pathways here, though, and we should acknowledge them, right? There's a common cause pathway here, confounding, right? It could be that there is something about cardiovascular disease or inflammation that causes hearing loss and causes cognitive decline, right? And so if true, intervening on hearing loss wouldn't do anything for dementia. There's selection bias. Who participates in our studies? Right? Some sort of systematic error to the way in which participants are selected. This especially is true for hearing aid research that I'll show an example in a minute. Or is there measurement error, right? Is there something about adults with hearing loss not being able to do a cognitive test, right? And we talked a little bit about that already. These are potential dangers to the way we do this. However, not just do we see the different tests, we also see that adults with dementia can actually do hearing tests really reliably. There was a belief for a while that this wasn't true, and then somebody actually tackled it who's sort of a brilliant neurologist that just decided to do the study showing test for test reliability for hearing measures of adults with dementia is comparable to adults with normal hearing or with normal cognitive function. So, two possible ways we can look at this. There are causal pathways and there are non-causal pathways. And with the non-causal pathways, we do our best, right, to get the best measurement. We do our best to understand whether or not the right participants can actually obtain the measures. We think a lot about confounding in our models. And, hearing loss is a cause, right? There are several pathways. We're not sure which is true. And there's so many things to consider here. And I think my personal take is we're not going to go deep on this, but the literature is still in its infancy. Even though it seems like we've had this big explosion, we've seen so much. I really think that there are, of those papers where we look at that 340% increase, a lot of them are just using self-report hearing. And self-report hearing would be, subject to some of those information biases, for example. Also different causal pathways where cognition affects how you self-report, right? And it's cognition does not seem to affect how you do the test if you do objective measures of hearing, but it would affect self-report hearing, right? We actually do see this as well as external factors. We see this in the NHAT study, where if you look during COVID, all of a sudden we actually have lower prevalence of hearing loss. People's hearing is getting better in the study. And it's because it's a self-report metric that's based off of how much difficulty you have in noisy situations like restaurants. But at a time when no one's going to restaurants, no one's really thinking as much about it. And lo and behold, now everyone's hearing is better. And there are multiple people who have tried to publish papers saying that hearing loss improved during COVID without, the deeper thought on logically, we actually can't improve hearing in that sense, right? And it is it does speak a lot to, I think, how where we sometimes lose track, I think, in public health of we get so obsessed with some of our statistical methods, we sort of take measures for face granted. And I am one here to say that I think our field in epidemiology is due for a reckoning at some point for all these papers that really are not thinking about the measures themselves. So we have our DAG here, right? We have our drawing of what could happen. And I think we want to know, what if you put hearing aids in here, right? And we've seen some work in the observational literature saying, okay, well, maybe we prevent cognitive decline. And we've honestly jumped to conclusions, right? These are from the CDC, Washington Post, New York Times. Without even evidence, before we finished a trial, we were getting information saying, hey, get hearing aids to protect your brain. But I think the question is that really an appropriate, is observational literature going to show us what we want? And there are two things that happen. One, we get a lot of studies like this. This is actually the study, full disclosure, is retracted. Jennifer Deal and myself wrote several commentaries on this. And one of the main problems, though, without even going deeper into their retraction, when you set up no hearing loss as the referent category, and then hearing loss, no hearing aids, and hearing loss, hearing aids as the comparison. And what they're saying in this is that if you have hearing loss and hearing aids, you have a similar incident dementia risk as those with no hearing loss. But I'm here to sort of say, without trying to get into too much jargon, it's not really feasible to assess a treatment effect with a referent group that are not at risk for what the treatment effect might modify. And what I mean by that is, if you don't have hearing loss, you cannot experience the phenomenon of hearing loss causing dementia, right? Which means you cannot see or experience the treatment effect of hearing aids modifying that. It's, if we were to think in terms of diabetes, you would not test the effects of metformin on non-diabetics to reduce diabetic impact, right? They don't have diabetes to begin with. You can't test that treatment effect pathway. And so we see this all the time. And sometimes this actually leads to the treatment effects in the treatment effects actually looking like they're worse because the people who get treatment often have some of the worst hearing loss. A good example of that is actually a Falls paper that was put out a few years ago. The authors put out a paper saying that hearing aids are associated with 2 times the risk of falls compared to no hearing loss. And, what we did was we redid the model where we limit it to hearing loss who use hearing aids and hearing loss who don't use hearing aids. And we actually saw that among hearing aid users in that model, falls reduced. And so I think one problem with the literature is we're often setting up the models wrong. And the other problem is even when we see an effect of hearing aids in those with hearing loss, like this paper, which was in JAMA, where we saw uh, those with older adults who had hearing loss who used hearing aids had lower risk of dementia. People who use hearing aids are different from those who don't, right? We have higher income, higher education levels, different help seeking behaviors, different perceptions of hearing loss. Observational data can mislead in this. We don't really know, right? We can do what we can with statistics to parse apart, but these are strongly associated, right? I told you before, only 20% of adults with hearing loss only use hearing aids. So it's clearly a very different group. It makes it hard to trust the observational data. People have done some difference in difference models, which I think are innovative, but I think at its core, observational findings might be confounded. We really need trials, right? And I think skipping right to it, our team led one of the first major randomized trials to examine hearing care on cognition. This is the Achieve trial. The PIs were Franklin and Joe Koresh of the initial trial. I was one of the MPIs of, or I was the PI of one of the ancillaries in the study, and now Jennifer Deal at Johns Hopkins is actually the PI of the ancillary. We're in our 6th year, I think, of collection now. The basis of the trial was could treating hearing loss reduce cognitive decline over 3 years? We measure a lot of other outcomes as well. The study design is 977 older adults. They are recruited from an existing cohort as well as new de novo community volunteers, 70 to 84 years of age, untreated hearing loss, normal cognition at baseline, randomized to best practice hearing intervention or a successful aging control that matches for the number of interactions with a healthcare professional. And then we look over 3 years. The study is nested within ERIC. ERIC is a study that's been ongoing since 1987, population-based epidemiologic study, longitudinal epidemiologic study to look at atherosclerosis risk in communities, very cardiovascular focused. And as I mentioned, around 240 of our participants actually come from that study. So around 240 actually have, decades of data on them before joining. And then we have these 740 who are very de novo new volunteers. Just if someone's interested, feel free to pull the slides. I couldn't help but put these in, but we don't really need to cover them deeply. It's just that we match the hearing intervention for the education control. The healthy education control is actually the 10 Keys, which is an established program from the University of Pittsburgh. These are things like, nutrition, diabetes control, physical activity, social interactions, encouraging just healthy behaviors. Our primary endpoint is change from baseline to 3-year global cognition. We measured every 6 months. We also have secondary domains like incident cognitive impairment, different cognitive function domains, memory, executive function, language, incident dementia, MCI. And then we have things like UCLA loneliness scale, depression, physical activity, falls, hospitalizations, healthcare costs. This is our neurocognitive test battery. It is 10 tests. We put them together to create factor scores, so we're looking within the groups and change. We have memory, executive function, and language domains, then a global cognitive score. Happy at any point to go deeper on this if somebody would like. It might be easier for email though, just because it can get burdensome. We also have those adjudicated dementia, adjudicated mild cognitive impairment. For the study, we got very lucky. The field sites closed for COVID right after we finished the initial intervention period. So everybody got their full intervention and recruitment. And then some people during some of the interim follow-up visits were on telehealth. But then we got, again, extremely lucky that all of the sites were open by the time we started 3-year visits. So we actually have our baseline and our 3-year clean from COVID protocols and COVID affecting our ability to measure people in person. But we also spent a ton of time and have some papers on our ability to do some of the data collection via telehealth. And honestly, the effect is different for COVID shutdowns at different sites. As you can imagine, one of our field sites is Mississippi. COVID shutdown was not very long there. Minneapolis, however, COVID shutdown was much longer. Statistical comparison, we're using mixed effects models adjusted for baseline hearing, recruitment source, field site, age, sex, education, presence of APOE, 4 alleles, covariate times time interactions. And we do base this off of intention to treat analyses, but we also have some CACEs or per protocol too. We recruited our 850 people. A note on, science and using it effectively. When you recruit out of an ongoing study, you sort of go out the gate with a bang, which doesn't always happen. And so one thing is this study was powered actually on 850 people. We asked NIH to give us another $1 million to get to 977 to overpower it just because we were doing well with our recruitment and we were hitting all of our recruitment targets very fast. Over the course of the study, we have follow-up on 90%. This was powered assuming 20% dropout, actually. So again, we very much are overpowered at this point to detect anything. For the basic idea of treating hearing loss, this is a measure called the Hearing Handicap Inventory. It's your perception of how hearing loss affects your life. In red, we have the intervention group. In blue, we have the control group. And as you can see, we drop precipitously after the intervention period, right, on the hearing care side, meaning that hearing loss is no longer, like as a proximal measure, it's not affecting their life as much. By 3 years, our cohort participants are wearing their hearing aids still on average 7.2 hours a day, which is more than in the community what we tend to see. Not everybody wears their hearing aids all day. They tend to wear them for events that they need them in. So this is pretty good. We're having relatively, we do have people who drop out of the study and stop using care, but we have pretty good participation throughout. I will jump to the 3-year cognitive change on the global as well as the subdomains. There is no effect. And when I say no effect, I will like point to that p-value and say 0.96. We have no effect on 3-year global cognitive change in the full cohort. However, in a pre-specified analysis of the ERIC cohort and the de novo cohort stratified, we do have an effective intervention in the ERIC cohort, 48% reduction in global cognitive decline. And I think the reason is this. Most of the time you would see these table ones at the beginning of my presentation. I save it for now, though, instead, because the ERIC cohort actually had much higher risk to observe cognitive decline throughout the period. We basically saw in the de novo cohort, no one in the control or intervention group changed cognitively over 3 years. Whereas we did see that movement on the ERIC group, and they were older to begin with, had poorer cognitive scores at baseline, had lower education, had higher rates of diabetes, higher cardiovascular disease rates. And so, when we start to interpret this, there is no effect overall. And we should really say that very cleanly. There's no effect overall, but in the less healthy existing volunteers, hearing intervention does reduce global cognitive decline over 3 years by 48%. In those healthier new volunteers, the de novo group, and this could be a healthy volunteer effect, which plagues older clinical trials of older adults. This could be a healthy volunteer effect where these are just the worried well, and they joined our trial and they were very unlikely to experience cognitive decline. In the words of John King, one of the NIA program officers, when we presented this and unveiled these results, he immediately said, well, yeah, this makes sense. Because you want to know who joins dementia studies in their 70s? Not people who are going to get dementia. So interpret with caution, but I think we decided to look a little bit deeper, and I'm going to zoom through this so we have time for, we started a little bit late, but I want to zoom through so we have time for questions. We decided to look at predicted risk versus observed effect, right? And so now what we're doing with this simulation study that we actually just published only a few months ago, led by James Pike on our team, we're deciding to say, let's look at the participants who have the greatest risk for cognitive decline, regardless of do they come from ERIC or Achieve, right, or de novo, right? And let's see if hearing intervention has greater reduction on cognitive decline in that group, right? So now we're saying it's not about, are you arbitrarily from this long-standing epidemiologic study where we think that, hey, these people joined in their 40s and they have higher risk factors and they would have never joined a study in their 70s. Now we're just saying, let's look at all the high-risk people. We created a model for prediction of cognitive decline in ERIC. So because we have the full ERIC sample, we looked at another 2,692 people that are in ERIC, not including those who joined Achieve, and said, okay, using all the data we have at our disposal, we can predict relatively accurately observed cognitive decline, right? And I'll actually just zoom ahead without beating down on this, but again, can go back if you'd like, but I want to have time for questions. If you think of it like this, and we use that risk model, so now we take the entire Achieve group, we've applied our risk model, we put them into quartiles of risk for cognitive decline over that 3-year period. And what we actually see is that the effective intervention is only present in the group with the highest risk of cognitive decline, the top quartile. If you were to do this as the mixed effects model, we actually get a 61% reduction in cognitive decline in the group in the top quartile risk for cognitive decline. So meaning everybody who has those same factors, older age, poorer cognition at baseline, higher cardiovascular disease rates, diabetes rates, lower education, that group, regardless of whether they're in ERIC or de novo, they are experiencing the greatest benefit. And it's not that we think, by any means that, hey, the poorest benefit, the highest risk group is the only one who's going to benefit from hearing care. I think a better interpretation is that 3 years is a pretty tight window to see cognitive decline. And unfortunately, in the NIH model, we're limited to these 5-year windows. It's about the best we can do to get 3 years even. It probably has way more to do with its just likelihood and propensity to change, which you can't measure prevention of cognitive decline if nobody changes. And so I don't want to mislead anyone to think, oh, only people who really, really need, or really have high risk for cognitive decline are going to benefit from hearing care. This is probably a phenomenon of ability to measure change within a study, period. So again, cognition takeaways. Hearing and cognition derives from population-based studies. We shouldn't interpret it on the individual level. The trial is null, but there is this sort of signal. There is a ton of work that needs to be done, though, on bidirectional synergies. We do have people dropping out of the study, and it is likely that some of those baseline factors that might put you at higher risk for cognitive decline also put you at high risk to cease using your hearing aids. It's possible that this has little to do with hearing care and more to do with just the effect of audiology care. One thing we don't talk about a lot in the study is after we balance the initial interactions and then the 6-month interactions, we actually do not balance for drop-in visits. And hearing care has a lot more drop-in visits, right? Hearing aids are highly technological devices. They have the same processing power as computers. They actually win awards at CES every year for their technology innovation, but you are putting it in your ear, which is disgusting. Without, I'll say that as a clinician. You're basically taking that laptop computer and dropping it in a swamp, right? So hearing aids do break a lot. They need a lot of treatment and maintenance, which means our hearing care side is actually seeing a healthcare professional significantly more than the other side. We do have other outcomes that I mentioned. I'll zoom through them a little bit. Loneliness and social isolation. We see an effect, a protective effect of hearing care on all loneliness and social isolation outcomes. For the loneliness one, we see a statistically significant effect in the full population, but this is not clinically meaningful at all. This really is not a big change. However, on the social network changes, we have characteristics on the number of people you interact with over a 2-week period, the diversity of those people, meaning, are you seeing the same person over and over again, or are you seeing a very diverse network of family, colleagues, neighbors, and then the embeddedness, which is like the quality. And we see significant effects across all of these. The social network size was actually one of the more eye-popping headlines we found where over the course of 3 years, hearing care was associated with retaining one additional person in your social network that you were seeing regularly, which is a lot. Average social networks range drastic. The range is very large, but the median and the mean, you're looking at like 10, 20 people. So an additional person, right, in that network can be a huge, huge factor. And for some people at the edge of those ranges, an additional person could be, 25% of your major social network. We also see some hints that the hearing care prevented falls, but it was really only during the first year. However, this may be sort of masked just because we see it start to come back in the third year. Just remember that in the second year and third year, right, we've had this post-COVID world where people have been isolated for a long time. They're not experiencing as many falls in general, actually, just for they're not doing as much physical activity. We do see some effect on fatigue scores. We have two different types of fatigue scores, and the fatigue score that has a little bit more of a cognitive fatigue to bend slant to it rather than physical fatigue actually is where we see the effect. We see no effect though on physical activity or accelerometry, which maybe wasn't something that we thought we'd see, but there were some hopes just because we've seen a lot of people who have put out observational data that says that adults with hearing loss are actually less physically active after their hearing loss. So some key takeaways in the whole study. We didn't even go over all the effects, but we've seen improved communication, reduced fatigue, potentially some reduced falls, definitely reduced social isolation and loneliness, in a less healthy group, 48% reduction in cognitive decline, but no effect on physical activity, no effect on depression or overall health related quality of life or physical function. We're starting to publish now a lot of brain atrophy papers, and we just published a paper on brain biomarkers with NFL and GFAP showing something that corroborated the cognitive findings, whereas the ERIC cohort also have reduced levels of NFL and GFAP over the 3-year period in the intervention group. Again, that strength of evidence, though, this association, we're starting to meet some of Bradford Hill's criteria for that causal framework. We are not all the way there though, and the evidence is in early stages. And I underline constantly, please interpret it on a population level, not necessarily the individual level, because it is something extremely prevalent. And it's important that we're able to sort of communicate this appropriately so that we don't scare people and say, hey, if you don't get hearing aids, you're going to get dementia. It's very unlikely that that would be the case. But if we got hearing care for the country, right? If we actually passed Medicare expansion to cover hearing care, which right now it's a statutory exclusion, that could affect dementia rates, right? That could actually significantly affect our bottom line as a country. So I will stop there. I still was able to keep 8 minutes, and I apologize that I raced through some slides. I really am happy to go back, but I'm sure there was time.